industry. Al Frankel is a leadership expert working at Pascal Metrics. Frank Drews is the human factors expert. He's actually based here at the Salt Lake City VA, and we'll also be featuring topics related to making the business case for change, a tested diffusion model from the Mayo Clinic, and change management strategies with some exciting reference tools that we'll be handing out to all those who are attending. We did send out the Readiness and Needs Assessment Survey, and as you know, we're trying to plan around your needs and where you're at. We need everybody's input, and we're waiting on about 10 final responses, so if you've not responded yet, please do so. For those of you who have responded, thank you very much. Based on the responses we've got so far, we have selected the second priority area as patient falls, and again, the June webinar will be focused on that topic. We're using your responses to finalize the measure set for comparative feedback reporting. So within the next 2 to 3 weeks, hopefully we'll have all the responses in and can begin to get those measures out to you and the mechanisms for reporting and sharing information so that you can get meaningful feedback. We will have follow-up calls to the Readiness Needs Assessment Survey, so Dr. Bruce Bailey and his colleagues will be calling with the primary contact at each hospital to follow up on success stories. We do note from the responses we got that there are a number of hospitals, and we've got key contacts and the facilities noted here, of those hospitals that have reported success stories in reducing early induction. Again, we'll collect more information from you on that and share it with the group. Here's an example slide with some information from Presbyterian Health System in Albuquerque, New Mexico, and the great achievements they've made building on work from the Joint Commission, ACOG, and then lastly using the IHI elective bundle. And we'll give you some websites at the very end of this presentation that will direct you to those slides. One thing I can let you know about, but I need to be vague at this time because it is a contract and it's not been finalized yet. But because of the Secretary of Health and Human Services commitment to the Strong Start initiative, there will be a small dollar amount that will be allocated to each hospital that is working on reduction of early inductions. We will be able to provide further details, we hope, in May of 2012. There'll be flexibility in how those funds can be used. It'll be approximately $2,500. This will be the only one of the 10 patient safety areas where there will be an incentive. And again, you can flexibly decide how your hospital would use that money related to this work. And again, more details will follow. I also want to remind people about the Strong Start for Mothers and Babies funding opportunity. That's a separate funding opportunity from CMS. If you're looking to test changes, they have revised the letter of intent deadline. That's not the proposal, that's just the deadline to March 21st, from March 21st to May 11th. So there's a little more time, and again, we can help you out with questions and answers that you may have. So without further ado, I'd like to turn it over to my colleagues, Dr. Ware Branch and Ms. Terry Keene, who are going to walk you through the specific work that we've done here at Intermountain. Thank you.
Thanks, Lucy. I assume sitting here is fine for the mission today is for Terry and I to go through our concepts here at Intermountain Healthcare with regard to eliminating elective deliveries less than 39 weeks. And I've organized this brief presentation around the notions as to why eliminating elective deliveries less than 39 weeks might be important, or actually why it is important, I should say. And then I want to talk about building out the process to achieve the goal of eliminating elective deliveries less than 39 weeks. There'll be time for questions and answers, of course, and I think those are best done at the end. And I have with me here in the room members of our process improvement team, of course, Terry Keene, but also Christy Nelson and Eric Henry, who are the IT folks, which are so critical to these efforts. So, am I in control of these? Yes. Okay. No, I'm not. Wait a minute. Hang on. As soon as I can change the slides, I will. Did I do anything? I think it's clicked off. Okay. Right. There's the disclosure statement everyone's familiar with. and our objectives are listed on this slide. The first two objectives are relatively obvious from the foregoing discussion. The third objective is to point out a relationship between poor choice for induction and cesarean section and length of labor, which indirectly is part of this whole effort. So I'm still, just 1 second. Did I do that? Oh. All right, there you go. So, I'm not very good with the computer. Sorry, folks. The problem, of course, in concept is trying to prevent early term births. And it's the robust use of induction that seems in part to have related or to have caused this problem. The rate of labor induction increased from 9.5% to about 20% from 1990 to 1998. And in some hospitals, by the early 2000s, in some hospitals, the rate of labor induction was as high as 40%. The clinicians on this webinar recognize the several reasons involved. Another presentation of those data through 2006 shown in this bar graph slide. And you can see in 1990 that a relatively small proportion of early preterm births at 37 to 38 weeks was replaced by a fairly much larger proportion in 2006. Some of those earlier inductions are going to be elective inductions less than 39 weeks. We also looked at the reality in Utah. These data, 1992 to 2006, in a line graph. And Eric Henry and others pulled birth certificate record data. The blue line represents patients induced because of a risk factor, that is, one or more risk factors. That you can determine on using birth control, birth certificate. We should all use birth control. Birth certificate data. And then the pink line represents those with no risk factors, and we assume those were elective inductions. And you can see the rise from about 15% to somewhere around 30%. So of concern. It turns out that electively delivering patients near term has its own burden with regard to neonatal morbidity and mortality. So in this study by Zhang and Kramer, a retrospective analysis of NCHS data, they looked at 12 million deliveries and found these facts. The adjusted odds ratios for low APGARs were higher at 37 weeks, and ventilation requirements more than 30 minutes higher at 37 weeks and at 38 weeks compared to the reference of 40 weeks. Perhaps more importantly, neonatal death odds ratios adjusted were higher, as were postnatal death odds ratios compared to 40 weeks. In an often quoted study looking at deliveries from elective repeat cesareans at term, poor composite outcomes, one or more of the following shown on the slide. Poor composite outcomes were seen in a higher proportion of infants delivered at 37, 38 weeks compared to those at 39 or 40 weeks. These are things that I believe most of the clinicians will recognize. Beginning in the early part of this millennium, we started to look at our own information regarding outcomes by gestational age week of delivery. And on this bar graph, you see NICU admissions. Vaginal deliveries are represented by the blue bars, and the green bars represent cesareans. And so NICU admissions are higher at 37 weeks, then at 38 weeks, then at 39 weeks, as you can see. And it's particularly concerning that in cesarean deliveries without complications, we think largely elective cesarean deliveries, repeat cesareans, the need for a NICU admission is relatively high at 37 weeks. RDS rates look similar in pattern, as does ventilator usage by week gestation, similar in pattern. And notice again the elective repeat cesarean rates. This issue of inducing patients plays an important role also in creating some maternal morbidity. There's a paper recently published from the Consortium on Safe Labor that looked at cesarean deliveries, primary cesarean deliveries in 12 U.S. clinical centers, I think involving about 19 hospitals. And in this cohort of patients, primarily taken from 2005 to 2008, 44% of women attempting vaginal delivery had been induced. Often it was difficult to be sure of the reason, but a goodly proportion were induced. And in this group, cesarean section rate was twice as high as in spontaneously laboring patients. We noticed this as well, and we used our Bishop score data to prove the point. Just a moment. You'll have to fix that because I don't have any clue. We used our Bishop score data to prove the point, and the worse the Bishop score, the higher the unplanned C-section rate. And I realize that's something of a duh to the experienced clinicians, but it's absolutely true. Multiparous act very differently than nulliparous, as the experienced clinicians also know. Yeah, you got it. It turns out that the average number of hours in labor and delivery for elective induction patients relates to the Bishop score as well. And I probably don't need to remind experienced clinicians that the Bishop score is, on average, less favorable at 37 weeks and at 38 weeks than it is at 39 weeks or 40 weeks. So you spend more time in labor and delivery and more medical care resources choosing to induce patients with a poor Bishop score, patients that are less well suited for induction. So early induction relates to this issue. Not surprisingly, the American College has weighed in on this. The American College of Obstetricians and Gynecologists has weighed in on this, pointing out that the benefits of labor induction must be weighed against the potential maternal and fetal risks associated with this procedure. And they strongly urge us to confirm the gestational age at 39 or greater weeks, as shown in the bulleted points below. So how can we get at this issue of eliminating less than 39-week elective deliveries in appropriately chosen patients for delivery? And this is where we want to talk about how to do it. So what we have done over the last decade or so is represented on this slide, and I'm going to argue that one needs to start by having a solid administrative infrastructure. We're going to talk about that in just a moment. Quite clearly, one has to have definitions of such things as what is an elective delivery less than 39 weeks, but other outcomes of significance as well, which I'll address in a few minutes. I guess it goes without saying that those definitions should be comparable from facility to facility or region to region around the country in order for process improvement across the country to be followed in a meaningful way. Really important is provider and patient education and participation. This is all about changing the mindset, changing the culture, something that's notoriously difficult to do. One then has to delineate the process itself as it will be played out at your own facility. And each facility within our system has nuances that require modifications in that facility as they might be compared to other facilities. And then monitoring, reporting, and enforcement are a final component and fairly obvious to anyone who's been involved in process improvement. So with regard to the administrative infrastructure, here's what we do, and I would argue for something similar to this, if not identical. The healthcare organization administration is at the top, of course. It has to be an administration that's committed to process improvement as a primary component of its game. And I should put that out to the right-hand side. I didn't. Our sort of governing board, stamp of approval board, if you will, is the guidance council for our process improvement effort in women and newborns. It might be called the quality improvement board, but it has to have the ear of the administration directly. In fact, I would argue administration bigwigs should be on the guidance council. And then the process improvement teams that we have within women and newborns are several, and it's at that level that one would do the work of designing and implementing a program to eliminate elective inductions less than 39 weeks or elective deliveries less than 39 weeks, for example. It may not be too obvious to those of you who have yet to put together process improvement teams, but the list of folks seen on this slide represents the kinds of people you need on the team. Managers on this conference call realize that teams can be too big to be functional. They can be so small as to be overshadowed by a strong personality. So you need a medium-sized, I'm going to argue, you need a medium-sized team that includes operations personnel, providers, trench nursing staff folks, people on the front lines, nurse administrators who often overlap with operations, an administration representative, we've talked about the importance of that, and then critical players are IT data personnel. They're absolutely necessary for understanding the monitoring piece, and some secretarial support. Those process improvement team members you choose have to be committed to process improvement. They can't just be anybody. They really have to care about the task of process improvement. And I can't overemphasize that, however obvious it may seem to the audience. They also have to be folks that attend meetings, and physicians are notorious in our part of the country for attending exactly 34% of all meetings. So we need people who will attend the meetings and participate. And they have to effectively and reliably communicate with the constituents back at their individual facilities, and this is a key feature. I can't tell you how many times I get to hear, well, no one ever told me. No, I didn't know that, you know, and that's something that one needs to strive every day to eliminate. With regard to definitions, on the front end of the process of eliminating elective deliveries less than 39 weeks, you have to understand parity, and we'll talk a little bit more about that in a few minutes. Most importantly, you have to understand what is the gestational age and how it's established. And I would argue for using the guidelines for perinatal care published by the college and the American Academy of Pediatrics, and that's what we've done. One also has to figure out a way to estimate the due date by computer, not one of those little wheels, but by computer. And I think the due date in an ideal design is understood by a scheduling office at least by 25 or 26 weeks of gestation in the current pregnancy. That way it's not so easily manipulated late in the pregnancy by folks who would game the system. And then, very, very importantly, you have to understand indications for induction, non-elective indications for induction, and we're going to talk more about that in a moment. In fact, we'll talk about it right now because here's the slide. So this happens to be our current, and you'll see it's revised list that are indications for delivery or induction of labor. And we work on this probably once every year or 18 months. This particular list, which you're welcome to use, is an amalgamation of indications from the college and from the Joint Commission. And Terry, is there anyone else? Yeah, from those two sources. Believe me, there's some controversial points on this, or in this table. Let's take diabetes, for example. Is gestational diabetes that's diet controlled an indication for induction or delivery? It's a somewhat debatable point the experts on the webinar would recognize. What is chronic hypertension? How does one define that? But the biggest bugaboo lies in logistics or psychosocial indications for delivery. And what we've argued for in our system is that the individual facilities prepare what they would consider legitimate logistical indications for induction or outright delivery at their facility. Always a matter of some debate, however. Why is it important? On this scatter plot, you see individual physicians represented. And the dots represent the percent of indicated inductions that those physicians claim. At the left-hand side of the slide, one sees the high-volume physicians, those doing the most deliveries, and so the confidence limits are more narrow, and those doing the least number of deliveries is seen out at the far right with wider confidence limits. But it doesn't take a statistician to understand there's fair variation represented on this slide. And so an imperative in eliminating elective deliveries less than 39 weeks would be to understand indicated inductions and indicated repeat cesareans in your system. We've tried to represent this in a couple of different ways, and I like this method relatively well. So what you see on this slide is inductions as a percent of all deliveries, and the light blue section at the bottom are these are all multiparous patients, by the way. The light blue is multiparous elective deliveries, and the green, the pale green, is indicated multiparous inductions. And so you can see most of the inductions done in multiparous patients in Intermountain Healthcare are elective, and a relatively constant proportion are indicated. This also allows you to look at our total inductions in one slide. Why is this important? Well, here is one of our hospitals, cleverly labeled Hospital A. And in that hospital, there were a lot of seemingly indicated inductions through January of 2011 when we discovered that logistics was used as a reason for indicated inductions very, very briskly at this facility. And once we, got tough on this, you can see that the proportion of inductions that were elective has been identified and represents a much larger proportion, something in line with the rest of the system. Right. On the process back end, the primary outcome you want to be measuring will be elective deliveries less than 39 weeks, whether they be repeat cesareans or inductions. But there are a number of other outcomes that are important. I've already mentioned indicated inductions. I think we'll all want to know our primary cesarean delivery rate and why those C-sections are being done. I believe in the future for the notion of accountable care, it would be useful to know the length of stay in labor and delivery, length of labor, if you will. Chorioamnionitis would be important to understand as well. And the adverse fetal outcomes include stillbirth and HIE, low 5-minute APGARs, and so forth. Macrosomia is on the list. And then the adverse neonatal outcomes are imperative to understand as well. I want to point out that, I'm going back to that slide, I want to point out that the stillbirth issue has come up in publication recently. We'll talk about that in a moment with regard to process improvement. So we'll talk about that in a moment. What is the definition of an elective delivery less than 39 weeks? Well, the Joint Commission thinks the numerator is as seen on the slide and that the denominator is as seen on the slide. At Intermountain, we've used a slightly different definition, and other ideas have been proffered. It's very likely we're all going to go to the Joint Commission definition as I understand the terrain and the way the wind is blowing. And I can certainly live with that. Eric Henry's pulled together our data to show how that would look in one system versus the next. And so here you see inappropriate elective delivery less than 39 weeks as calculated within our system. 2009 is the blue bar, 2010 is the wine or burgundy bar, and the pink or flesh-colored bar is 2011. And you see the Joint Commission method, the Intermountain method, and the method that uses all term deliveries. And we just need to all be on one page and using the same definitions here. The results will look a little different, but as long as we understand the denominator, we're just fine. Here you see the way we do it, and this is the way we present it at our monthly process improvement team meeting. This is the percent of elective deliveries less than 39 weeks within our system, expressed, as I have shown you before, as a proportion of all elective deliveries. There you go, right there. Other measurements that I think are potentially useful for a variety of reasons, but importantly because they relate to elective delivery: primary C-section, overall C-section, and average time or length of time in labor. One would have to define length of time in labor according to patient and delivery type: spontaneous labor, nulliparous patient, multiparous patient, induced labor, and so forth. On the process back end, some of these definitions are really easy, and some of them are harder, and we'd have to recognize that and come up with uniform definitions. The length of stay in labor and delivery versus the length of labor is a very good example of something that we found a sort of tough nut to crack. Length of stay in labor and delivery is ascertainable. Length of labor from a given dilation forward in a nulliparous patient is also ascertainable, but might be harder to agree upon. Chorioamnionitis is another good example of a diagnosis about which consensus is hard to reach. Is it just temperature elevation, and so on and so forth. The issue of stillbirth is something I said I would mention briefly. There was recently published from the Northeast a retrospective cohort study to estimate the effect of limiting elective deliveries less than 39 weeks on fetal neonatal outcomes. And they assessed singleton deliveries at or beyond 37 weeks before and after implementing a process improvement goal, to limit elective deliveries less than 39 weeks. And they found the median 1 and 5 minute APGAR scores would decrease in the post-implementation period by a little bit, not clinically important. They found the NICU admission rate was decreased in the post-implementation process time, as I would have expected. And macrosomia rate was slightly increased, though it didn't translate into an increased cesarean rate. But these investigators pointed out in their paper that the rate of stillbirth in 37 to 38 week gestations was elevated after implementation of their process improvement. And so this is concerning. If we're going to try to eliminate elective deliveries less than 39 weeks and a result of that would be stillbirth, oh my goodness. We wrote a letter to the editor to point out that 5 of the 7 stillbirths that they noted after implementation occurred in pregnancies with complications, and the complications are shown here on the slide. And for at least 3 of these, we feel that delivery would not be categorized as elective. We also took the time to peek at our stillbirth rate in ongoing pregnancies, and these are by week of gestation. And the blue bars represent the pre-elective induction guidelines, which we implemented in 98 to 2000. And the burgundy bars are the post-elective induction guidelines. And our stillbirth rate, if anything, is very slightly lower. I don't want to claim robust statistical significance, but ours is not elevated. We also noted that the rate of stillbirth fluctuates quite a bit from year to year based on relatively small numbers of stillbirths. And so you can see in the green line that the elective inductions less than 39 weeks dropping from the turn of the millennium forward in the Intermountain system. And then you see the 37 to 38 week stillbirth rate per 1,000 term deliveries, as expressed in the paper by Ehrenthal. And so some years look really good, and some years look, somewhat worse. And I believe one has to be careful not to take 1 or 2 years worth of data and make too much of it. Certainly worth following, though, and I would encourage us to consider following that as one parameter. Provider and patient education is important, and we've created standardized lectures and handouts certainly our handouts are standardized. Our lectures are not as well standardized, to be honest. But we do go through our goals on a monthly basis with our process improvement teams, and we send the providers their results on a quarterly basis. We'll go over those in a minute. Providers are sometimes tough to sell. And so one would have to start with why this is important and show the data and show the cost of doing business one way versus the other. Quote national guidelines and how important it is to stick to national guidelines with regard to a variety of issues, most importantly outcome, but also medical legal issues. And then I think it's time to introduce the concept of shared accountability because I think it's looming on the horizon. And simply put, it's very expensive to do elective deliveries in poorly selected patients relative to a better management scheme. The patient-oriented stuff is as important because many patients want to be delivered early for the sake of their mother visiting or they're uncomfortable, whatever. And so they participate in this, and we've spent time on that. The physicians have rather much enjoyed having us, the healthcare system, be blamed for a change in elective delivery guidelines. So here are some examples of our education documents. The middle one is a care process model written for physicians, and on either side you see the information, the fact sheet written for patients and families, one in Spanish and one in English. So down at the local level, you need to delineate the process, and so you have to establish a gestational age. And how do you do that, and when do you do that? We've talked briefly about it. We'll talk about it in a second again. You have to establish how you're going to schedule inductions. When will you allow it to happen, 32 weeks, 36 weeks, and so forth. Who gets to schedule the induction, and what training do they have, and how is the EDC confirmed? We have written guidelines for how one establishes the gestational age. They are copied almost word for word from the guidelines for perinatal care. This is what I suggest is an ideal plan, or somewhat ideal plan. We don't do it that well in all of our facilities, by the way, but we think this is how it ought to be done if it's going to be done well. So the EDC of a given patient in a OB/GYN practice is submitted to a scheduling office at 25 weeks gestation, or some number like that. You could argue 22 weeks, you could argue 25 weeks, whatever. And then somewhere in the later pregnancy, the patient is scheduled for an induction or a delivery. And at that point, the person doing the scheduling compares the gestational age on the day the patient would be scheduled to the EDC that had been previously turned in to be sure that these things go together in a logical fashion. Of course, if the patient delivers, the induction or the elective repeat cesarean is canceled, and one needs to take into account the consequences of that in terms of labor and delivery scheduling, because it has a lot to do with running the business of the labor and delivery. The scheduler, in our opinion, should not be the daily charge nurse or an average medical clerk. We've learned that putting the nurse in the role of being something of a policeman is not a great idea. The scheduler should be well educated regarding the process, and probably, at least initially, should have a scripted response for denying scheduling of a patient, something that one of us wrote down for that person to say. Of course, the scheduler will need to have a clear understanding of the chain of command, we've learned, because of angry providers. And they have to be dispassionate about that sort of concern. And at one of our facilities, we've located the C-section scheduling person in the surgery suite. And that person, who schedules major surgeries, including trauma surgeries, that person has the skin of a rhinoceros. So If the patient is not suitable for an elective induction, then the scheduler would say, no, you can't schedule the patient for an elective induction on that day. And if the provider on the phone or that provider's rep on the phone is angry or put out, then the scheduler should be able to say, here's the chain of command, and I've been instructed to have you follow that. What's really important, I mean, the slide states the obvious, I know, but what's really important is that the department chair or vice chair, the medical staff president, and the medical director or hospital administration representative, all be on the same page about this process improvement and other process improvements in the facility and be dedicated to those causes. They can't be namby-pamby about this. They have to be players. In our system, hospital administration bonus pay has something to do with process improvement goals being met. Well, you have to monitor, report, and enforce this stuff, and we have monthly and quarterly reporting. Elective deliveries less than 39 weeks are discussed at our monthly process improvement team meetings. We go over the data by system, region, facility, and sometimes by provider. We have an accounting of all indicated in elective deliveries, especially the ones that seem to fall out, so much so that we spent time on that earlier today. Other parameters that we follow and look at monthly include overall inductions, primary cesarean delivery rates, length of time in labor, and we are gearing up to be more, more passionate about looking at our repeat cesarean versus trial of labor data. So here's an example of a slide that we show in our monthly meeting. You've already seen it. This is the percent of elective deliveries less than 39 weeks gestation as a percentage of all elective deliveries. It is important to know about your total inductions, and they're seen in the green line here. And then you can track your indicated inductions and elective inductions to see how they might be changing. And you'll notice ours have changed just a little bit as we've gotten tough on clear definitions of indicated versus elective induction. This is a information sheet performance summary that we send to providers once every quarter, and it has a bunch of obstetric information on it. The second page includes data regarding elective deliveries less than 39 weeks, and you can see on this slide that this provider did 2 of these, which is a little higher than many in our system, as you can see out to the right-hand side. Sending this out does not guarantee providers look at it, but it's available for department chairs and other leaders in the organization as well. I mentioned to you that we had been concerned about inappropriately selecting patients for elective delivery based on likelihood of successful induction. And so on this slide, you see the percent of elective inductions done in nulliparous patients with a poor Bishop score. This is expressed as a percentage of all nulliparous patients. I'm looking at Eric Henry and making sure I have this right. And we've spent a lot of time and energy trying to get this straight because we felt that poorly chosen patients, and especially those less than 39 weeks who are more likely to have an unfavorable cervix, are going to translate into a higher cesarean rate and a higher cost of doing business rate. As it turns out, in conjunction with that, we found our average hours in labor and delivery for electively induced patients has dropped. Now, it's made some recent gains that I can't explain very well, but please know we track it and look for reasons. But we've had, I think, a modestly good success in dropping our time in labor and delivery for these people. Not all hospitals have gotten on board. The data shown here are the poorly chosen nulliparous patients at Hospital A, and you can see the percentage of these is much higher at Hospital A than you noted noted 2 slides ago. And this hospital has continued to do nulliparous inductions. Some of our facilities have proscribed nulliparous inductions, elective nulliparous inductions altogether. I think a pretty wise move if one is concerned about cesareans and length of time in labor. Another hospital in our system has gotten rid of such inductions. They've prescribed nulliparous deliveries, that are elective nulliparous deliveries, and have a better rate of wisely choosing those who are favorable. So they've dropped it down to 0 for all practical purposes. Hospital A's length of time in labor for electively induced patients is shown in the blue line. It's around 8.5 to 9 hours. Compare that to their spontaneously laboring patients' length of stay in labor and delivery is about 7 hours. Hospital B, the better performer with regard to nulliparous and elective inductions, not surprisingly, has elective induction times and spontaneous laboring times that pretty much overlap, which experienced clinicians would guess might be true. It turns out the cesarean section rate, the primary cesarean section rate, is higher in Hospital A, and the overall rate is the blue line, and that among the electively induced patients is the red line, with the means shown by the olive-colored line. Now, mind you, some of you on the phone are, I'd like to think anyway, looking at those numbers and thinking, oh my gosh, those are pretty low primary cesarean section rates. Utah is the second lowest overall cesarean section rate and primary C-section rate in the country after New Mexico, I think. And so ours are very good, but look at Hospital B. Primary cesarean rate overall is quite low indeed, and that among electively induced patients is very low. And of course, we track neonatal outcomes to be sure that no harm is being done. So we think that these maneuvers, eliminating the elective inductions less than 39 weeks, and trying to eliminate along with that poorly chosen elective inductions, and have helped us with maintain a low overall primary cesarean section rate and overall cesarean section rate. And ours are the two lowermost lines. The two upper lines are overall and primary, and the two lower lines are our overall and our primary in Utah at Intermountain Healthcare. So what do you need to do? Create an infrastructure if you don't have one. Help us all figure out what definitions we'll use, and then get folks educated, which will be a bear of a process, I promise. Delineate the process by which you're going to do this at the given facilities, at each facility, I think. And then, of course, always monitor, report, and figure out ways to help physicians and other providers and patients see their way clear to do the right thing. So I think we're done with that, and we should answer questions, right?
Yes. Thank you very much, Dr. Branch. Yep. I also would like to remind people, as you log off and go to log off, you'll get the continuing medical education, continuing education unit questionnaire that must be completed online to get credit. So we will take questions. These are the two resources that I referred to early on, the ARC Innovations Exchange. And if you go to this link, you'll see some details and tools associated with what we've done here at Intermountain that was posted by Terry Keenan, Janie Mann. And then the IHI Elective Induction Bundle that Presbyterian used can be found at this website. Let me turn it over to my colleagues to see if there are questions.
So we've got two questions that were posted in the Q&A box, and if you've got any questions, you can either post it in the Q&A box or click on the hand icon that's on your screen, and we can unmute the line. So the first question comes from Laura Durham, and she asks, can you speak to the source of the data presented, clinical versus administrative or coded data, and estimate resources required to report these on a regular basis?
Boy, I'm not sure I can estimate resources, to be perfectly honest. I think around the table I can ask my IT people how much FTE they contribute to women and newborns efforts alone, and I believe it's about 1, 2, 3 FTEs, 2 FTEs. 2.5 FTEs for data acquisition.
Data that's already in total.
Yeah. Yeah, these guys know how to get it out of the data warehouse.
Yeah, so that's data that's already in a data warehouse, so that doesn't include chart abstraction costs.
There you go.
And we know that some hospitals are needing to do that based on their IT systems, and that's across an entire system of care.
We do about 32,000 deliveries a year in our system. So those are relative terms. 2.5 FTEs, electronic medical record system that's pretty good, and 32,000 deliveries. I hope that answer sort of helps.
And it's a clinical system rather than an administrative system.
Right. Our EMR is clinical. We get a lot of information out of a clinical labor and delivery electronic medical record.
Great. Thank you for the question. Jason, is there another one?
Yeah, there's another question from Laurel again, and she asked, can you speak to the guidance council membership? Is this OB New specific, or are they on members, or are there one member of the group? And what level is it? Hospital, regional, etc.?
This is Terry Keene.
Our guidance council is a system-level council, and it includes not only physicians, nursing, but it also has operational people on it to help with some of the cost issues that are associated with putting forth quality improvement projects.
And women and newborn specific.
And it's women and newborn specific, yes.
Yes, it is. The administration representatives cross over into some other specialties, though. Like Barbara. Yeah.
Other questions, Jason?
Okay, there's no questions. So again, post them on the Q&A box, or hit the hand button to raise your hand, and we'll unmute your line.
Yeah, we're still waiting for questions. Dr. Branch, did you have a point you wanted to make?
Yeah, I mean, so what Lucy Savitz and I were discussing earlier today was the notion of perhaps sending out a one-page document with suggestions regarding administrative, the pieces that we just went over, and including those definitions, so that we might gather together in a coordinated way to move forward. And so one spin-off of this kind of webinar would be the generation of that document hopefully for your good use, or to tear it up and throw it in the trash, I guess, but hopefully for your good use.
Yeah, and let me just say about that, the Strong Start initiative and trying to address the problem of reduction of unnecessary early induction is a requirement of the pledged hospitals, and it's something that the Secretary of Health and Human Services is very much committed to. So again, there will be a modest amount of resources that will come to each hospital that you can flexibly use. So for example, if you wanted to come to the in-person meeting and use that for travel, or if there were professional development opportunities for your staff, those would be ways you could use that money. So we're hoping that everybody will join us on that journey. Again, we're going to start sending out the information and setting up the relationships so that we can begin sharing measured data with the same numerator and denominator, so we can compare across systems. And we will, it looks from the Readiness Needs Assessment Survey that the Joint Commission definition is the most commonly used definition, and so we would all then want to use that same definition, and we will then work to give you useful comparative reports so that we're comparing similar hospitals to similar hospitals. We know we have a lot of rural hospitals in our group, for example, and so we want to be sure we give you meaningful comparative information. Jason, any questions that have come up so far?
There are no questions.
Let me just stop and ask Terry or Eric or Christy, any thoughts that you have just reflecting on the information or the journey you've been on, lessons learned?
Oh, boy. Well, I mean, I guess I'd say on the front end of this is Dr. Branch. I'd say on the front end of this process that if your facility or system doesn't have any of these initiatives in place, that there is looming in front of you some culture change that's not very simple, because patients and physicians are probably accustomed to hedging a little bit on when they may be delivered. And that suits some needs, to be sure. Convenience needs for the physician, and that's important to the doc. And I think convenience and a certain sense of family needs on the part of the patient. And individual physicians and individual patients don't necessarily think about system-wide goals and the utilization of healthcare resources. well, they certainly don't think about them very clearly, I think. I'm going to argue in this case. And so be aware that this is a challenge that's a bit different from taking on the challenge of, say, curing cancer. Everyone gets behind curing cancer. I mean, that's what's difficult about that. So be prepared to interact with folks who may be slightly to modestly critical, and to respond with data.
Great, thank you.
And just be aware, if you are pulling data, initially you're going to have a lot of questions on its accuracy. So be prepared to be able to go back and show where the data came from and give some really good resources, because, again, providers are going to say, well, this patient was different, this data is inaccurate, and you need to be able to go back and provide them with the source data so that they understand. It might even be as specific as providing by patient name, which we often do.
That's a very good point, Terry.
Yeah. Eric, any observations on pulling the data and preparing these reports that you do on a regular basis?
Just that anytime you start something new, you'll find problems with the data, like they're saying, and to work with people and for data people to be open to that there are issues, and as we share it back, and we're trying to help them understand that we're trying to get the most accurate data so that we have reports that make sense and have things that are helpful.
Great, thank you, Eric. So one of the things that we will be doing, as I said early on when I introduced the topic, is collecting success stories from other hospitals that are part of our HEN. And we will be putting that out on the website for you so that you can have contacts and network with your colleagues who are on the same learning journey with you. If you have specific questions about making implementation and change around this particular area, you can send a note to admin@henlearner.org, and we'd be happy to field those questions from you and solicit expert advice in helping you move forward on that journey. Jason, any other questions?
No question.
Great. Well, please be sure, if you want CME or CEU credit, to be sure to complete the online questionnaire following this as you're logging off. Any other logistical things, Jason or Amy? No. Great. Well, thank you very much.
Thanks a lot.
We'll be sending out the one-page summary within the next 2 weeks, and we will also be sending out the detailed information on May 18th or 17th and 18th in-person meeting later this week. Thank you.